I'm going to turn it over to Maria. She's going to talk to you all about our race and ethnicity data and all the great work she's been doing in that space.
Good afternoon, everyone. I hope you are all enjoying this sunny afternoon. Thank you for joining us. As Kerry mentioned before, the race ethnicity data was also shared in the same space, which is what is in the Colorado APCD data. And the motivation behind that is, again, like all the questions that we received from several stakeholders about what is the state of the race ethnicity data in the Colorado APCD. What you're gonna find in that resources section that Kerry showed is a spreadsheet that looks like the one in the screen, and you have the count and percentage of all the data fields that are related to race and ethnicity in the Colorado APCD. The data that is shown for 2019 and 2020. And it shows also the breakdown by payer type, that is all the commercial payers, Medicaid, Medicare, and Medicare Advantage in some cases. Could you go to the next one, Kerry, please? The intention of showing this data is not so much to represent the race ethnicity distribution in the Colorado APCD, because when you look at the data, you're gonna see, this doesn't look like the race and ethnicity distribution of our population. It doesn't yet. But it was also motivated by the fact that in 2019, late 2019, 2 of the race and ethnicity fields became required for our submitters to provide. So for such, since the Colorado APCD was established back in 2012, as Kerry mentioned, these race and ethnicity data fields have existed, but they were submitted only in voluntary basis. So the data was very limited and just mostly incomplete. In late 2019, the regulation changed and 2 of these data fields became required. The 2 data fields required are race and one that is a Hispanic indicator. The Colorado APCD is closely following the model that is the federal government model from the Office of Management and Budget. And that model recognizes only one ethnicity, which is being Latino or Hispanic, and a minimum of 5 races in a different field. Those are the fields that are required now in the APCD, but we also collect another 2 more race fields and 3 more ethnicity fields. So in total, we have 7 data fields that refer to race and ethnicity. Could you go to the next one, Kerry? Okay. Usually following the model of the Office of Management and Budget, what you do is you do a combination of the ethnicity field, so you are either Hispanic or Latino or not, and the race fields. In this case, the race fields are white, Black, American Indian or Alaska Native, Native Hawaiian or other Pacific Islander, and we also have an other race field and an unknown field. In some cases, some of the payers, and I think that's Medicaid, uses also the more than one race. But most of our submitters only have the 6, including other and unknown. When we do the combination of race and ethnicity, what you have is like they are independent fields. So you can be Latino white or you can be Latino Black. So that's the creation of these mutually exclusive categories. And the reason I am showing them to you is just to point out that even when these 2 fields have become required, that doesn't mean that they are complete or they accurately represent the distribution of race ethnicity in the state of Colorado. For example, the blue bar represents the percentage of reported as unknown by commercial payers, which is still very large. We only have 1 payer in the state of Colorado that reports race and ethnicity in a very complete manner, and that would be the Medicaid, the state agency. But for the other payers, we have still a lot of work in front of us. Next one, please. So the next steps to improve this, we have to take this data, and that's the way that's one of the reasons also we are sharing. This is a data, is a baseline in a way, because these data fields became required just last year. And we are working actively with payers to capture more complete race and ethnicity data. We are also updating the data submission guide to give more precise instructions for this coming year, and also in the future to add more specific race and ethnicity field, and potentially add another variable or data field that provides information about the language that members or patients have. But because all this information is being improved, and we are actively working on to increase the capabilities of the Colorado APCD of informing healthcare equity and health equity in general. One of the other initiatives that we have been working on is geocoding the Colorado APCD. And we're going to be talking a little more about that. So first of all, what is geocoding, right? In the Colorado APCD, we receive information about the members who are covered and about the providers who provide the services. All these members and these providers have addresses. These addresses are, the process of geocoding is a computational process to assign a latitude and longitude coordinate, and that coordinate provides us with the ability of adding a geographic identifier. In our case, we have linked with a geographic identifier using the census model. So that will, and we used an external tool to do that, and we have completed that phase of the work. So that is very exciting, and we'll talk more about why this is exciting. This is exciting because we are now going to be able to speak about the context which each of the members in the Colorado APCD lives, works, and play. We're going to know if they have what is at the community level, the characteristics of their housing at the community level, what is the socioeconomic status at the community level. They have what is the limit in transportation access, for example, and income, race, ethnicity, and many other variables that can provide great information to speak about opportunities of improvement for healthcare and healthcare access and healthcare quality also. Having these geographic identifiers is going to allow us to use census data to speak to socioeconomic status variables and other variables, but also to many other data sets that are already available publicly that have aggregated a series of other pieces of information. You can also have information about the environment. You can have many different types of information. Could you go to the next one, Carrie? For example, you also know this is another thing that having geographic identifiers is going to allow us to do. If you are familiar with the data we present in our website, you know that we always present the information at the Division of Insurance region, at the county level, and in some cases we have presented the zip code level because that is the only information we have geographically in the data set right now. But now that we have the geographic identifiers, we can aggregate the information in much smaller geographic units like census tract from the census. The geocoding also allows us to have specific locations of members and providers, and that serves to answer questions like how far a determined patient has to drive to receive primary care services. We can actually use software, specialized software, to estimate the traveling time, and instead of just a gross estimate that goes from the centroid of a zip code to another centroid of a zip code. So this is going to allow us for much more sophisticated and important analysis in terms of access to care. Next one, please. And these are courtesy of our great data analyst, Katie Oberg, who has been working very hard in the geocoding project for the Colorado APCD. Just to give you an idea of the level of information that having having the possibility of displaying the data at a smaller geographic unit is going to give us. Look at the northeast region of this map. This is the prevalence of high cholesterol by county. We don't have the legend, but let's think that the darker means higher percentages of high cholesterol. So, and now look at the, could you go to the next one? And this is the same variable, but now is broken by census tract. What you see is completely different, and what you see, depending on who you are, let's say that you are a provider working in the Northeast quadrant. Now you know that you don't need to, you have much more precise information on where the population that are at high risk are in your area of service. Before you just had like the whole county as a whole, and you know those rural counties, so that's really not very helpful. Now you have much more information to actually target your resources if you are a provider, and if you are a researcher, is that if you target and you can find different types of relationships that are much more important. Next one, please. So the potential is great, as I mentioned before, because there are many data sets that are already available that use this type of geographic identifiers from the census. And we can link information from surveys that are available at the census tract level or at the county level, like health behaviors, socioeconomic information, as I mentioned, but also environmental variables. Like we know that air pollution and exposure to some chemicals can have important effects in the health of populations, and now we might have the possibility to do that. So we are very excited about the potential. Could you go to the next one, please? So we completed the phase of geocoding all the addresses, as I said, the addresses of patients and the addresses of providers. And this data is already living in the data warehouse. So every patient has not only an address, but also a geographic identifier that will allow us the linkage. In the near future, we will have a series of variables of socioeconomic indicators that are like most commonly used. But until we develop all of them, we will be creating those on an ad hoc basis. We are planning to do this annually. So every year we will be geocoding any new addresses that are submitted to the Colorado APCD. It is important to mention, of course, that we will be able to link our information with other data sources as long as they are available at the census tract level. For example, many surveys that are great information, the way they conducted their sampling, they are not available at the census tract level. So even if we want to link them that way, we will have to rely on county or zip code or anything that is available. But it is still giving us a whole new a series of opportunities of improving the context that we can provide to the healthcare data quality and healthcare access that we provide regularly in the public reports. And that's all I have to say for that.